I'm really impressed by the quality of today's program, and I'm really excited that the Life Sciences Bridge is something that we're continuing to do with the Swedish American Chamber of Commerce. And I think there's crises in the Nordic ecosystem, in the US ecosystem, and the more that we can help each other get through that and more rapidly get solutions to the patient is very beneficial. And I think as I embarked on introducing our next speaker, I also think about how we're all collaborating here. Some of us are sitting in United States, some of us are sitting in the Nordic countries, some might be Swedish immigrants that have come in this generations, and others might be those who have come in an earlier generation. And I think with that, I'm going to introduce Michael Osterholm, who is from Iowa, northeastern Iowa. My husband's from northwestern Iowa. And another thing which I love about when sometimes people here, we have Minnesota and New England, San Diego and San Francisco, the entire map of the United States represented. And Michael Osterholm, it's quite an honor to have you here. Michael Osterholm, PhD and Masters of Public Health, is a Regents Professor and McKnight Presidential Endowed Chair in Public Health. He is the Director of the Center for Infectious Disease Research and Policy. He's also a distinguished teaching professor in the Division of Environmental Health Sciences, School of Public Health, a professor in Technological Leadership Institute at the College of Science and Engineering, as well as an adjunct professor in the medical school, all of this at the beautiful University of Minnesota. In November 2020, Dr. Osterholm was appointed to President-elect Joe Biden's, or now President, Joe Biden's COVID-19 Transition Advisory Board. From June 2018 through May 2019, Dr. Osterholm served as a science envoy for health security on behalf of the US Department of State. He's also on the Luther College Board of Regents. Dr. Osterholm is the author of 2 New York Times bestselling books. In 2000, he authored Living Terrors, What Americans Need to Know to Survive the Coming Bioterrorist Catastrophe, laying out why the biological attacks like the 2001 anthrax attack are a new reality and what we must do to prepare. And his 2017 book, Deadliest Enemy, Our War Against Killer Germs, details the most pressing infectious disease threats of our day, including the coronavirus and pandemics, and lays out a strategy to address them. So clearly, we cannot thank you enough for the work that you did to help the world really deal with the COVID-19 pandemic and to plan ahead for whatever pandemics may lay ahead. So thank you so much, Dr. Osterholm, for being here, and take it away. Hey, Dr. Osterholm.
Hi there.
Hi, how are you doing?
Good, thanks.
All these things with technology, but we know the audience is excited to hear from you.
Oh, good. Well, happy to help however I can.
Wonderful, thank you. So I gave a wonderful presentation of you already.
Oh, wow.
So wonderful things. I guess what I want to make sure, in case you didn't hear it, is just how grateful we are that you are working so hard, first worldwide for all of us to deal with the COVID pandemic and to plan ahead for whatever pandemics lay ahead.
Well, thank you. Appreciate that. Yep.
So really, really wonderful to have you here. And I would say with that, I think everybody's back and you can go ahead, and we are excited to hear from you. So thank you, Dr. Osterholm.
Thank you. So I assume this is going to be kind of a fireside chat, questions and answers. That's
yes, exactly.
Okay, got it. So, okay.
I just want to make sure, what I do want to tell the audience is just to make sure that everybody feels that they can put some questions in the Q&A that they would like for me to ask. But I think in terms of where we are now with the pandemic, and we know China just ended their lockdown COVID restrictions in San Francisco. In healthcare settings, we're still kind of doing it. I would like to hear from you, kind of some of your thoughts just of where we are on that, since it's still with us.
Well, first of all, thank you very much for having me. I appreciate the opportunity to be here. Obviously, with my last name as it is, that by itself should give you some indication of my allegiance. Although I do have to tell you, it's a very interesting story. When my great-great-grandfather came over from Sweden through Ellis Island late one afternoon, as he went to sign in, they informed him that there had been too many Petersons that day. And so he had to need to pick another name for his last name. And they can't come from the Eastern Islands. So Osterholm, Swedish. So that's how I got my last name. Actually was an Ellis Island decision. So, but still, nonetheless, the Swedish roots are there. In terms of the current status of the pandemic, let me just provide a caveat to say that this virus continues to throw 210-mile-an-hour curveballs at us. So anything I tell you has to be kept in mind that, wait till tomorrow. But I'm happy to report that we're probably in the best place globally with this pandemic since 2020. Right now, the overall deaths in the world have come down substantially. Even in the last 2 to 3 weeks, we're seeing decreases. Now, some of that is clearly due to the dismantling of the surveillance activities we had in many countries and many states. But even when we look here in the United States, where a lot of people are not being tested by PCR in laboratories where those results would get reported, but rather being tested by lateral flow tests at home, which those results don't get reported. When we look at hospitalizations and deaths, we can surely see the numbers are coming down. Right now, we're averaging about 160 deaths a day in the United States, which is surely south of that 350 to 500 deaths a day we had just 2 months ago. And throughout most of the pandemic at that level or higher. Globally, the same thing is true. One of the challenges we have, however, is the fact that there is a new variant that's been emerging in India that has caused a flare-up of activity there, but a flare-up that I would have to say, given the 1.4 billion people in India, still reflects a relatively much lesser public health challenge than we had in the early days of the pandemic. But this new XBB 1.6 subvariant, we'll have to see what it does. In the meantime, what we want to do is make sure that those at highest risk for serious illness, hospitalizations, and deaths do get vaccinated again with this booster. You heard that last week, the FDA and the CDC approved a second bivalent booster for those that already had one. And this is really important because the data are clear and compelling that within about 6 months of your last dose of vaccine, or for that matter, even previous infection, you become vulnerable again to basically being at risk for the disease. And so by continuing to be vaccinated, at least at that time period of 6 months, it boosts your immune system back up. And while it wanes over time, much like influenza virus does, if you look at seasonal flu, we vaccinate in the fall season, anticipating the winter months when flu is most likely to be spread, because in fact, that vaccine may lose about 15% of its protection per month after you've been vaccinated. And so 5 or 6 months out, it really doesn't provide very much protection. We see the same thing largely with the issue of SARS-CoV-2. There may be some more residual protection against serious illness, but it still needs to be boosted up. So again, I recommend everyone to do that. 97% of the deaths in the United States today are in people 50 years of age and older. About 93% are in those 65 years of age and older, or who have underlying health conditions that would put them at risk. So in a sense, these are the people we need to really be working hard to protect as best as we can. So at this point, I'd like to say we're on the other side of the boundary with this pandemic. I think it's a little bit too early. I've said for the last 3 years, I'll know when the pandemic is over, a year from the time that it ended. When we really saw lack of ongoing activity, and that in fact it maintained itself. So stay tuned. You did note about for the future, I'm actually working on a new book right now about what would it be like if this was the big one. This was not the big one, as much as it's caused us such pain and suffering and losing over 1.1 million Americans to this virus. And that is not just a number, that's a lot of people's moms and dads and brothers and sisters and cousins and aunts and uncles, and unfortunately even some of our children have died. So I don't want to minimize that, but if this were like 1918, influenza, which still influenza poses a risk of a pandemic, we would have seen anywhere from 6 to 8 times the number of deaths that we saw with this particular pandemic. If this was like some of the other coronaviruses, like SARS or MERS, viruses that in the past have caused us problems, that too would be very different. And the reason that SARS and MERS weren't a bigger problem is they were not very infectious. Transmission was limited. With this one, it's highly infectious. SARS and MERS killed between 15 to 35% of the people that got it. Here, we saw less than 0.5% of 1%. Now imagine if in fact we have the same level of transmission as we see with SARS-CoV-2, the current pandemic virus, with the ability to kill the way that SARS or MERS did. And you could see how this would be a very, very, very different situation. So some of us are working very hard right now on saying, what are the lessons learned? What are the things we should know? How do we start preparing? And far too often in public health, we prepare when the crisis happens. We kind of go from rags to riches. You get support when something happens, you don't when you're not. And we've got to get out of that mindset. Today, if the US government and the Department of Defense propose a new aircraft carrier, from the time that it's actually approved until the time it's actually in the water sailing is almost 12 years. And yet we pay that entire time. We commit to making sure that that particular aircraft carrier is fully built, maintained, and gotten in onto the oceans. With our vaccines today, it's hit and miss. I mean, we don't really do that. And we have to understand that that's really a big challenge. So the bottom line message is good news is that things are surely getting better. But if you're in high risk for a serious illness, hospitalization, deaths, you still have to be mindful of getting your vaccine, in particular, wearing an N95 respirator if you're in places with lots of people. And if you do get sick, make sure you get Paxlovid immediately. That particular drug can do a lot to reduce serious illness, hospitalizations, and deaths. And it also reduces your likelihood of getting long COVID.
Well, thank you for that, Dr. Osterholm. I also wonder if you could address, we have a question from the audience in terms of over the past few years, especially during this pandemic. Of course, all of us heard that vaccine had become, whether or not to vaccinate became very politicized, not just in the United States, but in the world. How do you think that we as a society might address this? Do you have some ideas on this?
Well, I have never been really big into the concept of solving problems with the following equation, A plus B plus C plus miracle. That just doesn't work very well. And right now, I have to say, I lean more towards A plus B plus C plus miracle. We are severely challenged. The mis and disinformation is growing in leaps and bounds, has become very politicized. Some of us have just done a recent analysis. And as hard as this is to say, if you look at in those states, particularly the red states, and again, I'm not here to politicize something, the data are the data. If you look in those states where people were not vaccinated, likely well over 200,000 people in this country died because they refused to be vaccinated. Think about that. And it was primarily in red states and people who refused to be vaccinated. So ideologically, you can say, well, this virus did this, did that, did that. But from a political persuasion standpoint, you did this, this, and this that puts you at risk for having that virus do what it did. And I think this has been a big challenge. How do you depoliticize this? I've worked for the last 6 presidential administrations. I was a science envoy for the State Department during the Trump administration. I served 5 governors in Minnesota when I was a state epidemiologist, 2 Republicans, 2 Democrats, and as I affectionately say, 1 independent wrestler. And no one would know my partisan politics. I'm there for public health purposes. I'm here. All of us have a right and a need for good public health practice. And yet today, it's become so politicized. I'm used to being in tough spots, I outbreaks and so forth, but I never had imagined the kind of death threats and the kind of challenging that I would receive just trying to do my job with COVID. Well, when you're at that level of angst and you're at that level of disagreement, it becomes a real challenge. I also worry very, very much about AI going into the future, artificial intelligence. I am predicting that within months, you will see people like myself, my face, my image, my voice on social media saying vaccines are going to kill you. I should have told you that before. I've just come to that revelation. Don't get them. And of course, we know that that's not me, but that's someone trying to spread messages for which the public will say, well, I saw Dr. Osterholm, or I saw Dr. Hotez, or I saw Dr. Fauci, I saw all these people say these things. Oh my, how was I so fooled? And I think that the disinformation is only going to get much worse. And it's really a challenge. I mean, right now, just in the last day, the state of Mississippi has had some of the worst public health outcomes in all of the country with so many of their programs, socioeconomic, race-based, diversity, et cetera. But they had one thing. They had a very strong immunization law that did not permit religious objections for vaccination. And they had the highest rate of childhood immunizations in the entire country. Yesterday, a judge in Mississippi overturned that and now are allowing parents to beg out of vaccines if they want for school entry. I mean, we're undoing many of the very positive things we've had. So it's a very important question, a very good question. I wish I had better answers. We are surely thinking a lot about that. How do you communicate with the public? I have had personal friends who I have communicated with during the course of the pandemic who refused to be vaccinated, and they didn't trust me. And, we've been friends for years. One of them actually died from their COVID infection and wouldn't get vaccinated. So I think it's a much, much bigger issue than just simply saying you got to do a better job of education. We're in a whole new era right now of, what is misinformation, disinformation, what people believe, what people assume is their right to assert whatever they want. So I wish I had more information or better data on that. Just know that it's top of list for us. We think about it all the time and what we can do to provide more assistance in our communities to address this issue. It's huge.
So it's almost where we take the vaccines for granted, and then when new things come along, people start questioning the new vaccine, even though we've actually benefited from a lot of these immunizations that our children had or that we had as children. So,
if I could add context to this, I think is one of the things that people don't really realize. In 1900, average life expectancy in the United States was 42 years. 80,000 generations from the caves to basically the life expectancy of 42 years. Okay. Since that time and up through COVID's reduced it. We're now at 78 years. For every 3 days we've lived as humans in this country, we've gained 1 day of life expectancy since 1900. And why was that? It's not high-tech medicine. It's safe water. It's safe food, it's vaccinations, and to some degree, it's antibiotics. And we think that we have this modern medical healthcare system that's doing all this to extend our lives. No, it's because a whole lot of babies aren't dying. It's because a whole lot of young children are not dying. It's because young adults are not dying. And I think that people take for granted how powerful and important public health is. When you don't have safe water, when you don't have sanitation, you don't have refrigeration, you don't have safe food, you don't have vaccines. And I think this is a real challenge, because when you look at where our resources go, less than 1% of our federal health care dollar goes to public health and prevention. So much of it goes to treative medicine, high-tech medicine, et cetera, which, surely all of us want to have. But at the base root of all of this health that we get, we have to remember how important public health is, and vaccines are playing a very critical role in that. And around the world, they're playing a critical role. So I can't say it with any more stronger terms. The fact is that these are invaluable tools, that there's a lot of people in this world today that didn't die as young children because they got vaccinated. Now, no one will ever know that. There won't be a grateful public health worker that somebody will go find and say, thank you for saving my son's life or my daughter's life or my life. But that in fact is exactly the case.
Well, thank you for that. I do wonder, and of course, we are, talking about the impact of life sciences on innovation on healthcare here. But as with your perspective of public health, I can't help but ask, what do you think of the other, since we know that when people had more comorbidities, other things where it affected them more, and the access to healthcare and the racism part was also something that came out. As an example, for telehealth medicine, do you see that as one of your toolkits now in public health to continue? Are we in the United States or worldwide getting better at using tools to provide the care where people are?
We are getting better, and telemedicine is surely an example of that. But we have to understand our healthcare system in this country is really a disease care system, not a healthcare. It's disease care, and it's severely broken. Look right here in the Twin Cities. Our neonatal intensive care units in the Twin Cities have been on divert many days in the last month. There's no crisis happening in terms of outbreak. It's because they don't have capacity anymore. And fortunately for telemedicine, some of these kids are being cared for in rural hospitals that should never be being cared for there, but they're trying their best. Look at today at mental health issues. Go look at Hennepin County Medical Center right now for where adolescents with acute mental health crises are being held. They had to evacuate the ambulance garage and put petitions in to hold kids there, sometimes 2 to 3 days before they can get a bed in the hospital. Most recent numbers I've seen says over 50% of the people in occupying beds in the state of Minnesota right now are occupying them because they can't get down to step down or to long-term care beds, so they don't exist. And so I think one of the things we have to recognize is we have this inherent conflict between high-tech medicine, which is amazing, and basic health care or disease care that's critical. And we're not dealing with it. We're still living in a world of 1968 Medicare-funded healthcare in a modern world. Nobody wants to have pediatric beds right now because if you look at reimbursement, they lose money handed over fist. And I come from a university. How many millions of dollars a year are they losing right now in healthcare costs? And so I think that it's time that we have to take a step back and ask fundamental questions of what are we really doing? And by the way, the issue on divert is happening all over the country. I was just on the phone call with one of the leaders of the major hospital in Boston yesterday, and their hospital is on divert. And there's no crisis. This is just normal book of business. They're not able to handle it. So I think that as we talk about healthcare in this country, we need to just take a step back and be honest. What are we really talking about? What is access to care? And in your question, I think you laid out very nicely. Yeah, there's great disparities by racial, socioeconomic, geographic. I mean, you don't want to be a woman today living in rural Minnesota and trying to deliver a baby. The access to, good and solid OB/GYN care is really limited. And so, I know that this may sound severe and strident, but it's the truth. And what we have to understand is, well, why is this then? What is it that we can do something about here? How do we discuss this? It shouldn't be a debate between parties. It should be, okay, these are the problems. Stop telling us we have the best healthcare system in the world. We don't. Now, does that mean when I say that we don't? Yes, surely for some of us who have access to good healthcare, insurance, access to medical plans, we may get more high-tech medicine in a lot of places in the world in a more timely way. But if you look at the very basics of healthcare, i.e. disease care delivery, our country's in big trouble. If you look at the public health emergency that's now basically ending because of the legislation, anywhere from 20 to 30 million people are going to be kicked off of Medicaid rolls. This is happening right now. Where do they go? Who do they get to take care of them? And so I think that this is a time for us to take a step back and ask, what are we doing? How are we doing it? What should be our goals? How do we prioritize who does have access? how do we pay for it? What do we pay for? And I think that that's a hard thing to address, because people automatically assume you're trying to basically, ration care. You're trying to do things. No, you're just trying to be realistic and say, what's the situation? And if it's one of your children that needs mental health crisis intervention right now, good luck. Good luck. That's a hard thing to say, but it's true. So I'm not sure I answered the question you wanted me to answer. And I'm not sure I gave the answer you would want, even if you did ask, if that was the question you asked me, but it's the truth. And, maybe it's my old age, I'm one of the things I find, the older I get, the more vulnerable I am to learning. And also the more responsibility I think I have to say what I really see and what I believe to be true.
Well, thank you for that. I think it's a stark reality, and I think we like to think we are moving in the right direction, but maybe we're not moving fast enough. But I think the way you put it, really, that we do have the opportunities for the high tech and kind of the precision medicine that we all hope for, but then yet there's all the wraparound and all the other things in terms of the access. We've had wonderful speakers today on trying to get to the root of diabetes type 1, and we know obesity and diabetes is one, so that the cost of care when we're just throwing medicine at all people in the same way, rather than understanding their own genetic makeup. How can we get to the root of what's causing, let's say, diabetes or obesity, and do that? So since we have such an international audience here, and I think everybody knows Sweden had a very different lockdown mandate than United States had, I want to broaden the question rather than comparing United States or Sweden and other countries less restrictive lockdowns. What do you think, in a bigger way, the way of international collaboration during the pandemic to get the vaccines out quickly, what do you think we've learned from each other's different ways of doing and our ways of collaborating? And what are we learning from each other so that we more quickly can get to advances and take care of people?
Yeah. Well, first of all, thank you for giving me another 2 hours to touch on this. Okay.
Of course.
It's a complicated issue. But let me just say, first of all, lockdowns by name, I don't know what the hell it means. Okay. Because if you look all around the world, we talked about lockdowns, and they weren't really that at all. Take, for example, Minnesota. I bet you'll be surprised to learn that when Governor Walz issued an executive order in March of 2020, it basically said, the use is a stay-home order unless you're an essential worker. Do you know that 82% of all Minnesota workers were declared essential workers? I mean, that wasn't a lockdown. And then it was lifted. If you look around the world, many instances were very similar to that in terms of what was actually enforced or what was put forward. It also mattered a lot when you did it. I actually wrote an op-ed piece in the Washington Post in April of 2020 saying lockdowns were not the way to go, because lockdowns inferred this kind of long-term permanent, we're going to suppress the virus. We all along had said we may need to flatten the curve. Meaning that, and I had projected in early April of 2020 that we would likely see over 800,000 deaths in the United States in the next 18 months. And CNN did a piece 18 months later when we hit 800,000 deaths. And I saw that this was going to be a many-year experience, not a couple of months. And so you couldn't keep locked down theoretically or, in reality for that long. So, but if you had a healthcare system where you were literally tipping over the top and you had no one to work because they were sick, you had then, to try to limit social interaction could at least slow down that. So rather than having 1,000 cases in your community in 1 week, you have 1,000 cases in 6 weeks, where you slow it down, because it's still going to happen. This is a zero-sum game. And, when we got done as this pandemic, 90-some% of us have been infected or, still protected from vaccine. And remember, we didn't have vaccine in that first year. So I think that, first of all, you have to understand that. Second of all, is when I've said you got locked down, Sweden let up early in that first year. But again, what they did wasn't just let up. I mean, you looked at how. And they ended up having really very poor results, even though the media was reported as such. And by the time the 3 years of the cumulative pandemic were done, they had higher mortality rates in Sweden than either did Finland or Norway, and who had a more parsed lockdown / approach. And so part of it is that it also mattered. If you look at the different waves, the alpha wave that occurred in early 2021, you looked at the delta wave that occurred at the end of 2021 and through the summer and early fall, and then you looked at the Omicron wave that came in late 2021 and then into 2022. It mattered when you got hit. For example, China. China put into place this very totalitarian oversight lockdown kind of picture where people were prohibited from leaving their homes, etc. Okay. And over time, they began to rebel against this, even though there was very limited transmission in China. But it got to the point where, and I had written a piece in the New York Times in February of a year ago saying, this is crazy what China's doing, because Omicron is so highly infectious, it's going to blow through their basic lockdown kind of approach. And imagine Alpha and Delta were like really severe forest fires. They were a challenge, but you could put them out. Trying to deal with Omicron was like trying to stop the wind. It was that infectious. And sure enough, between the social pressures and then the increasing transmission of Omicron, they let it rip. And, for a month this past year, they were in desperate straits. They lost over 1 million people in 10 days. But if you look overall, they actually look really pretty good globally because they had enough people vaccinated that they had lower rates. Had that same Omicron wiped through China before they had some vaccine out a year before, they would have been in terrible shape. So part of the challenge we have in trying to help people understand who did well, who didn't, in some ways was the luck of the draw. When did you get hit with your waves, and with what variant did you get hit? And that in the end, the only thing that really, really made a big difference was vaccine. I will just say right now, I am a very, very strong supporter of respiratory protection. But most of the respiratory protection we used in this country was absolutely BS, that's simple. Surgical masks, procedure masks did not stop aerosol-related transmission either to or from. You needed an N95 respirator. Yet we saw hospitals throughout the entire country, that's what they put on their healthcare workers or their patients. I had 4 different instances during the pandemic where I went into a hospital for a reason in which I had my N95 on, and every one of those I was stopped at the front desk. So, well, you can't wear that. You have to wear this procedure mask. That's our policy here. I mean, talk about really bad. And so even there, unless you were adequately wearing the right protection, most people who wore a mask did very little to protect themselves at all. You had to have that N95 respirator as an aerosol. And if you want to know what an aerosol is, which is how this virus is being transmitted, go stand in a 30 by 40 foot room and have somebody stand in the corner and smoke a cigarette. Within no time, you'll smell it no matter where you are in the room. That's an aerosol. And so I think that that's the challenge. So which countries actually did well with respiratory protection? That too was another issue. So what we should have learned from this is that we have a lot to learn, and that we need to go back. And that's what I'm trying to do in my new book, is actually lay out what were the lessons learned about vaccines, respiratory protection, bringing the public with us. When in my piece in the Washington Post, I said clearly early in 2020, if you think you're going to lock down society for months and months and months, it isn't going to happen. And what you're going to do is just make them upset, and they won't trust or believe you in almost anything else. So there's a lot that we have to go back and learn, so that in have future pandemics, we are covered to address those issues.
Well, thank you so much for this. And I know we're limited on time, and we can't wait to hear from your, read your new book.
Thank you.
But I guess if you have the crystal ball looking forward, where do you recommend, other than us buying your book, what agencies or what international groups do you think are doing exciting things to kind of take the successes we've had from the what we learned and working on vaccines and the mRNA vaccines, and where do you see some of the hope, the bright spots, I guess, just to leave the audience with something?
Yeah, Well, obviously I'm biased, but our center led an international effort with 50 of the leading experts in coronaviruses, vaccines, et cetera, to develop a coronavirus vaccine roadmap. We have a lot of work to do to get better vaccines. We've probably maximized mRNA as much as we can. Remember, that's just a platform. That's something you put an antigen on. It's not actually the vaccine as you think of what's going to elicit the immune response. And we know with influenza and coronaviruses, we've always had a problem mounting persistent, durable protection. I mean, look at why do we do annual flu shots? Okay, but we get 2 doses of measles vaccine and we're done for life, likely. So how do we bridge that? And so this roadmap that we created, which has been released, it was a source of a major webinar last week that included even White House participation, is in fact an 8-year plan to say, if we do everything from A to B, B to C, C to D, we can get there. You're not going to get the miracle vaccine all of a sudden. And even for those that think that happened with mRNAs, it didn't. mRNA vaccines have been in the works for over a decade. But for cancer, it was just brought out and used for this. And so I think that our group, if you go to our website, we have news every day. We have a lot of resources for coronavirus response. There's a lot on respiratory protection, the vaccine. So the CIDRAP website, www.cidrap.umn.edu, it's all free.
Well, thank you so much for that.
Thank
and
you.
It was wonderful to have this conversation with you, Dr. Osterholm.
Thank you very
and
much.
Keep up
Bye-bye.
the great work.
Bye-bye.
You.
Thank you.
Bye.